Hi, everyone. That's my Cheryl voice. We're going to go over the neurodegenerative diseases, just do a brief overview of those. For the pretty much a definition of neurodegenerative diseases, it's a blanket term for diseases that involve any kind of progressive loss of selected neurons in specific brain areas, resulting in characteristic disorders of movement, cognition, or of both. For the history, I assume that people probably thought demons were involved somewhere, but historically it started with brain dissections on cadavers, and there were symptoms that were being shown and people were trying to figure out what was going on. The strange behaviors and the loss of motor control began to be attributed to brain disease after the autopsies were performed on the afflicted patients. The exact causes aren't really known, but they're attributed to genetic or environmental factors, and some are just idiopathic. Neurology in general was initially viewed as a specialty for diagnosing through physical exams, so the doctors could see the patients but didn't really know how to treat it. So it was just, this is what's wrong with you, and then you deal with taking care of the symptoms. This branch of research has expanded greatly in the last few decades, so a lot of research in it started about 40 years ago, and that was when they could really start seeing more of the brain. Now we can do the use of MRIs, CT scans, and we can see, instead of using cadavers, we can see with the live patients what is going on with their brain. For the epidemiological trends, neurodegenerative diseases are generally age-dependent. A lot of them occur with older patients, but as we know, some of them are earlier onset and some of them start with at a younger age. Now, due to the longer life expectancies, the prevalence of these diseases is increasing in the elderly population. So we're seeing more people with these diseases just because we have more older patients. In the US, Alzheimer's is the most common, and it's also the dementias just in general are most common, Alzheimer's is being the most common dementia. 5.4 million people in the United States are afflicted with this disease, 44 million people worldwide, and 2 out of 3 patients are women, so it affects women more often. The other most common diseases that we're going to see: Parkinson's, which Kelsey's going to go over in more depth; Huntington's, which is a genetic disorder affecting 30,000 people in the United States; and then amyotrophic lateral sclerosis affects 4 in every 100,000 people. Men 1.5 times more likely to develop it than women. For the defining features, since it's such a blanket term, it's pretty general, but there's a progressive loss of cognitive function, motor function, or both. The focus is usually just managing these conditions. To generalize them, we have dementias, which are Alzheimer's and frontotemporal dementia. The defining features of Alzheimer's is disordered cognitive function. Short-term memory loss is usually the first symptom, progresses to difficulty in language processing, speech, disorientation, mood swings, and then later stages can progress to total loss of speech and memory, and then complete dependence on caregivers. Akinetic rigid diseases such as Parkinson's, it's a disabling motor impairment disorder. Kelsey's going to be going over Parkinson's more in detail. Huntington disease is a hyperkinetic movement disorder. The hallmark is excessive and abnormal movement. We've learned that as chorea. Early symptoms include restlessness, lack of coordination, saccadic eye movement, characteristic jerky and uncontrollable movements. It progresses to cause a difficulty in swallowing, chewing, and speaking. The cognitive abilities worsen, and some people develop neuropsychiatric disorders and depression. Motor neuron disorders, such as multiple sclerosis and amyotrophic lateral sclerosis, ALS, or Lou Gehrig's, is a progressive weakness and muscle atrophy. It's a progressive degeneration of voluntary motor neurons, upper and lower, complications with ambulating, speech and swallowing, and it can become fatal when it progresses to affect the neurons of the respiratory system. And there's also ataxic disorders such as spinal muscular atrophy and spinocerebellar ataxia. On the next slide, where I just put a table of the overview of the classification. So you have the type, the clinical features, and the anatomic basis. I'm not going to run through all of that because it'll take too long, so you can look at it yourself. And I'll send it over to Kelsey.
Hello, everyone. I'm going to be talking a little bit more about Parkinson's disease. We chose to focus a little bit more on this one just to narrow down for ourselves and for future presenters. In terms of exercise and diet, we want to specify one specific disease, and we chose Parkinson's disease. So just a brief overview and a history. It's a neurological disease determined by James Parkinson in 1817. It was originally called the shaking palsy, which has now evolved and formed into Parkinson's disease that we know today. As far as historical trends, there was hints of Parkinson's disease reported going back until 1000 BC, excuse me. This was mostly due because the symptoms. So you can see symptoms further back in history of tremors and fascinating gaits and bradykinesia and everything having to do with Parkinson's disease as early as 1000 BC. Often it was missed as a diagnosis in the early years, mostly because if you had a comorbidity such as heart disease or another type of comorbidity, it would take priority over Parkinson's disease. And at the time, there wasn't much research saying that it was a complete different disease. So a lot of times, physicians just overlooked it. To continue trends, there has been a general increase in the past 30 years. Men are 1.5 times more likely to develop Parkinson's disease over females. About 60,000 Americans are diagnosed a year, and over 10 million people in the world are affected about right now. And with most neurodegenerative diseases, the risk increases with age. Kevin's going to talk a little bit more about this and how physiologically this would be a case. Defining features, we all know the 4 cardinal signs of Parkinson's disease, being bradykinesia, slow motions, resting tremors, muscle rigidity, and postural instability. As we all also know, there are several defining features that all patients don't necessarily have, but they could have, such as pedestal turning, fascinating gait, retropulsion, and micrographia. And on the next slide, we have a little bit more of the symptoms, including gait, which varies depending on patient, micrographia, which is small writing, hypophonia, which is soft speech. They often could be expressionless. They can display pedestal turning, which is taking several small steps in order to turn, retropulsion, emotional and cognitive decline. And with branching off of the emotional and cognitive decline, we're starting to see more research into proprioceptive loss and perception. As Ben mentions all the time, he believes Parkinson's disease is more associated with perception, and we see this a lot with the FOG, the freezing of gait, and there's continuing research into the perceptual decline of Parkinson's disease. To assess for Parkinson's, there's no one specific test that can diagnose it. However, there are several clinical tests that can be performed to evaluate symptoms. Some of these including the timed up and go, the Berg Balance Assessment, and the Functional Reach Test, which is pictured here. These tests are used to rule out other possible diagnoses, and as I mentioned before, Parkinson's gets progressively worse with age. And now Kevin's going to talk a little bit more about the pathophysiology.
So this being a neurodegenerative disease, there's not a lot known about it, but what we do know is what I'll be talking about today. So mainly speaking, there are two different types of ways of getting Parkinson's disease. You can have sporadic Parkinson's disease, which could be from anything like toxins or the mitochondria of the pars compacta dying, or maybe there's a theory going around of oxidative metabolites. But either way, these factors destroy the pars compacta, which results in Parkinson's disease. And then there's inherited Parkinson's disease, which is a mutation which creates the overexpression of a protein called alpha-synuclein. And so the aggregation of misfolded proteins, alpha-synuclein, forms in the cell bodies of the neurons in the pars compacta. And these cell bodies are then called Lewy bodies. They displace and destroy all the dopaminergic neurons for the direct and indirect pathway. And this leads to a loss of dopamine production in the basal ganglia. So the impact this has on the body is that it disrupts the motor circuit. The motor circuit is basically between the cortex, the basal ganglia, the thalamus, and then back up to the cortex again, where it'll go down the pyramidal pathway. So what happens here is that with that being disrupted, you lose the initiation of voluntary movement and procedural learning. So complicated learned movements like bowling or swinging a baseball bat, all of a sudden, instead of knowing this one fluid motion, it's now broken down. You have to use voluntary cognitive load to control how you move. It makes it a lot harder. So in the basal ganglia, the default state of the basal ganglia is inhibiting movement. And it also has direct connections to gait and balance through the brainstem and spinal cord. So not only are the direct and indirect pathways affected, you also lose some ability to control your gait and balance, which is seen in the symptoms of Parkinson's disease. So the direct pathway, it basically inhibits the inhibition on the thalamocortical pathways that are exiting the cortex to promote voluntary movement. So basically what that means is that any information going from the thalamus to the cortex is allowed to pass. And the indirect pathway, which is the normal for the basal ganglia, the default state, exciting this leads to the inhibition of any of that information making it to the cortex. So the only way that voluntary movement happens is the secretion of dopamine from the pars compacta, initiating the direct pathway. This also plays a role in procedural learning and reward-based behavior. If you have like a goal and your body sees that as rewarding behavior, such as eating food, it'll release dopamine and basically rewires the circuitry to behave in a way that'll be beneficial to the organism. And messing with these pathways, you see the disruption of learned or automatic movements and the increased need for voluntary or cognitive control.
All right, and so now I'm going to talk a little bit about some of the different treatments for Parkinson's disease. Probably the most common one is just treating it with medications, probably because it's the quickest and easiest and involves the least amount of involvement for the patient. There's a bunch of different kinds of medications that can be used to treat Parkinson's. But I'm just going to go over a few of the three primary ones, especially because they're the ones that, as PTs, if we saw a patient, there's probably a higher likelihood that this is what they would be taking. The most common one is levodopa or L-dopa, and sometimes the patients will also take Sinemet. L-dopa basically crosses the blood-brain barrier before being converted into dopamine in the brain, activating those pathways that Kevin touched on previously. Sinemet is a combination of L-dopa and carbidopa. This combination is beneficial in a lot of cases because it prevents L-dopa from being broken down before it crosses the blood-brain barrier, lowering the required dosage of L-dopa that needs to be taken And this is important because while a lot of these medications are really beneficial for reducing the symptoms of Parkinson's, they do have some negative side effects. And in some cases, those negative side effects can actually outweigh the benefits that patients will get from taking these medications. Dopamine agonists are usually prescribed before L-Dopa or Sinemet in many cases because they have a lot fewer side effects than L-Dopa or Sinemet. So if these dopamine agonists are able to correct the majority of the symptoms that a patient has, then that's usually sufficient. Some of the negative side effects of dopamine agonists include nausea, dizziness, hallucinations, vomiting, and confusion. A lot of these symptoms are pretty universal across the board as far as side effects, but there are some that are worse. Safinamide is another one that's common. This one is usually taken alongside L-Dopa in patients with Parkinson's. Usually it's taken if a patient who has been taking L-Dopa starts to have an increase or a resurgence in their Parkinson's symptoms, then this might be taken in conjunction with L-Dopa rather than increasing the dosage of L-Dopa alone. And one benefit of safinamide is that it can reduce the symptoms, and it can increase the time that a patient is symptom-free. One downside with a lot of these, even L-Dopa, is that some of the side effects are pretty severe, and they tend to get worse the longer you take it, which has become a larger issue now that the prognosis for Parkinson's has improved, and patients are living with Parkinson's for 10 years or even 2 or 3 decades at this point with the disease. So usually somewhere along those lines, they might encounter some side effects like severe hallucinations, arrhythmias, loss of appetite, blurred vision, and other things that may cause a patient to opt out of taking their medication. And because these medications are so efficient in treating the symptoms for Parkinson's, a lot of times physical therapists may not necessarily see everybody with Parkinson's disease just because their medications cover most of the symptoms and allow them to go on with their daily lives. But next, I'm going to talk about some of the treatments that us as physical therapists might do if we're trained in them. So there's a treatment called LSVT, or Lee Silverman Voice Treatment. And it's a behavioral motor control treatment. There's 2 main subsets, LSVT loud and LSVT big. One common issue with Parkinson's, that patients with Parkinson's have, is that they tend to speak in a softer voice, and they have a hard time articulating what they're trying to say or adding expression and tone to their voice. So a lot of times people have to ask them to repeat what they said. So LSVT loud focuses on trying to get patients to be more vocal, improving their volume, their cadence, and the general way that they speak. Most of these sessions for both LSVT loud and big usually will be about 16 sessions, about 4 times a week for 4 weeks, and each session will be an hour long. And then there's always a home exercise program that accompanies it that usually should be completed daily. So the turnaround with both of these programs is pretty efficient in improving patients' ability to speak and move. LSVT big focuses more on the gross motor movements to help improve gait and daily function. It can help adjust the perception of a patient's movements, kind of to allow them to see how they move through what other people may perceive. Because a lot of times a patient with Parkinson's might think that they're moving fine or that they're speaking adequately loud when they're in reality not. And LSVT big focuses on a lot of large dynamic purposeful movements to help improve their functional gait and movement patterns and things like that. So the main takeaway for this, I know we focused mostly on Parkinson's disease, but that was mostly just because neurodegenerative diseases covers a really wide array and variety of different diseases, and it's difficult because a lot of the onset and causes of these diseases complicated and difficult, and for many of them we don't know where the cause comes from. And it's also difficult because they're progressive diseases that tend to get worse over time and with age. And even though there are a really wide variety of these diseases, many of them have characteristic traits that help us in identifying them and also give us an idea of how we should create an intervention for each disease or for each patient based on what those deficits associated with the disease may be. And as time goes on, we keep finding new ideas and knowledge on these diseases that help alter the way that we treat them, kind of in the way of how we're starting to view Parkinson's disease specifically as having a large perceptual issue rather than just being a neurodegenerative disease.
Okay, and so here are a few of our references. If you have any questions, please feel free to comment on the discussion board and we will try and get back to you. And thank you for listening.